Just come to me. We have done about 100 implants now, and I have to take a next step. Sometime I'm going to get an IP1 or an IP2 or an IP3. So then, you know, then he made me realize that Sumit, you just have to follow these steps. The prognosis and everything has been done, and it's a learning curve for me. And if I attend so many and present data in national international conference, it is still a great challenge. There is an anatomical classification which is on paper, but let me tell you, there is nothing which is fixed. There is nothing which is fixed, especially outcome related. And I think audiologists and therapists who are here, they would agree with me that my job is just to insert an electrode which is absolutely normal. The only thing you make sure is you don't enter into the internal aortic canal, you don't cause a gusher which never stops, patient has a meningitis. My job is to give you an almost full insertion and intraop NRIs or maybe a good subtended arc in the cochlea. But then outcomes extremely vary according to the type of anomaly. I'm going to make it very simple, just simple mathematics. Again, the golden rule is follow the basics and try and capture the 80% part of anomalies. Rest 20, it is still evolving. You may think it is this, somebody may think it is IP2 or it is an incomplete variant of type 2 incomplete partition. I had one case and I spoke to Dr. Murali and finally we realized that it was either IP2 or IP3, it was somewhere which was again a variant of IP2. And finally the results at the end, the parents want to hear, will you be able to do implantation to my child? I know it's a problem case. Or will you be able to give results? Will my child speak? Will my child be able to go to a normal school? So that's a golden question. And to understand this, I'll try and make this presentation simple. I am still learning, so I will try and answer to most of your queries. But then, as I said, maybe 2 years, 3 years down the line when we meet, I may become more rational and more wise to answer some more of your queries. Now to start with, we've already spoken about need of radiology in a normal CT scan in a normal ear. Now this we are talking is about the 10% which I left in my first talk, where I said that you need to focus on the 90%. And this is the 10% that is inner ear anomalies. Now Park et al. In 2000 said that 21% of patients with sensory loss had an inner ear anomaly. That's a staggering percentage. 21% is too high. Now how does a radiology or maybe a discussion with your radiologist can help you implant a child? You can make a wise decision to offer a CI in a patient with inner ear malformation. Now, how it can help you? For example, in case of certain anomalies, the decision to offer a CI is taken early. We will discuss about it. What are those anomalies where you should think about doing a CI? You should counsel parents that see your child has got this. Like for example, a Montanari deformity. If you see a Montanari deformity, the presentation may vary to an extent that a child even at the age of 5 years will have an almost maybe a mild to moderate sensory loss, because the hearing loss varies in cases of a Montanari deformity and it may go to profound maybe in the next year. So a careful and repeat audiological evaluation is required. Now if you know that you are dealing with a patient like IP1, IP3 and common cavity. See, IP2 I am not talking because IP2 is a classical Montanari deformity. So if you are dealing with patients who are less likely to achieve benefit, you get patients and I was also of this type that no, you have to put your child on hearing aid. The parents would say that we don't have money. But if you have a scientific calculation and you can say to a family like, look, your child is having a common cavity and IP1 and 3 and there are very less likely chance that your child will gain some benefit with hearing aid. And what you will lose is brain plasticity. What you will lose is the rehabilitation phase. So you have to keep your foot down, but before you keep your foot down, you should know what type of anomaly you are seeing. Now in patients with IP2, that is Montanari or LVS, large vestibular aqueduct syndrome, the hearing levels may be suitable for hearing aids. So this is very important. If you suspect a patient may be having a near normal audiogram but may complain of a sudden loss of hearing, just one episode which may recover in a child please get a CT scan done for the child. Don't take it otherwise. Tell me, all of you must be practicing. Do you see a child having a sudden sensory loss? Has any one of you seen a child having a sensory loss? We see it in adults because of diabetes, hypertension, viral attacks, sudden losses, noise induced. But in a child, if a parent or a child gives a history that this child had a brief episode of hearing loss, which is otherwise normal, or maybe a vertigo attack, don't take it lightly. Evaluate this child with a CT scan, and what you may gather, you are having a Montague with a nearly normal audiogram. So counsel the parents that your child may have to undergo serial audiograms, and whenever the hearing starts to fall, you can offer a hearing aid, and maybe at a later stage when it becomes profound, this child will be a candidate for a cochlear implant. Now, along with this, if you are dealing a case of labyrinthine aplasia or a cochlear aplasia, you know that there is no point giving a hearing aid trial or a cochlear implant. So straight away counsel the family for quadrilateral basement implant. Don't waste your time. This again comes back to the basics that you have started, you have done your homework for your radiology, and you know how it is. Now, inner ear malformation constitute about 20% of quadrilateral sensory losses. 21% one study said, and one study said 20%. Now, there are two major surgical problems as far as surgeon perspective is there. Now, there is a surgeon perspective and there is an audiology perspective. Surgeon perspective is a CSF leak or a gusher and meningitis. Now, you were just asking how to judge which cases would have a gusher and which cases will not have a gusher. And facial nerve anomalies. Now, this is very, very important. So, if we go back to the history, now, Jacob et al. Classification, which was based on polytomography in 1987, they gave a classification, a baseline outline, which they classify into Michel, cochlear aplasia, common cavity, cochlear hypoplasia, and incomplete partition. But there was no clarity. What does incomplete partition involve? And it was the earlier classification, like Dr.Murali said, it was based on embryogenesis and developmental arrest. Which month of intrauterine the arrest takes place, and it will give rise to a separate anomaly according to the gestational age arrest. Now, it was Levitt-Senekulu and Satsi in 2002 who actually studied the histology of the cochlea, basically at the mid-modular section. That is the area where they studied the modulus and the interscalar septum, and they classified these anomalies into IP1, IP2 and IP3. It has been recently introduced, called as X-linked. Recently, now in the latest literature, there is one IP4 as well. But I will not confuse you, so let's get to these three basic things. Again, stress why we need a CT scan in such cases. Now, it is good for classifying these anomalies. Facial nerve anomalies. That is even more important because we expect a lot of facial nerve anomalies in the tympanic and the mastoid segment in these cases. Internal auditory canal evaluation, that is the width of the internal auditory canal, because the width is going to tell you that whether you are dealing with a case of cochlear hypoplasia or aplasia. And middle ear evaluation or mastoid anatomy, which can help you in deciding that whether you want to go for a transmastoid facial recess approach, you want to take a transcanal approach, or you want to go for a transmastoid translabyrinthine. Now, what is the role of MRI in inner ear anomaly? Most important, if you see a cochlear anomaly case, you need to get an MRI, that is nerves in internal auditory canal, and you want to see the cochlear fluids. These two things should be on your mind, which you should discuss with your radiologist, that I want a section where I want to see the arrangement of the nerves in the internal auditory canal, and if it is internal auditory canal stenosis, go to the CPI. Go to one level up, so that you can trace those nerves and you can identify those nerves in the internal auditory canal. Now, you may come across, and generally we don't understand, practically speaking we don't understand, there are spin sequences, there is fat separations. These are three I have deliberately included because I have come across 3-4 studies in Europe, in US, and maybe some places in India, at like we do a true FISP study at Madden. Now, there are 3 specific modes which can be used in an MRI, which can give you an indication about the arrangement of nerves and the fluid intensity in the cochlea. One is a three-dimensional Fourier transform constructive interference in steady state. True fast imaging is what we are doing with steady procession. These two things, if you can go to your radiologist, sit with your technician and ask them what all different MRI imaging modalities and options we have for such lesions. Now, what we see, we look for cochlear fibrosis, that is a decreased signal intensity in the inner ear fluid. This is very important. You see the nerves in the CP ankle rather than interaortic canal if you are suspecting a stenotic IAC. Like if the diameter is less than 2.5, you should suspect a narrowing of the IAC and you should go for one level up to raise this nerve. Now ask your radiologist to make sections should be made perpendicular to the nerves and IAC. This is the best section where you will be able to identify these four nerves in the interaortic canal where you can trace the falciform ligament at the pitch bar. Although, don't get kind of upset if you can't see these nerve arrangement which is clear. Many of the cases of cochlear anomalies, the vestibular nerve superior and inferior, they are fused together. We are fine with that, but what we need is to just one nerve to see whether the cochlear nerve is there or not. Literature says if 30% of the nerve fibers are there, a cochlear implant will give the child the benefit. And ABI should only be considered once these kids don't do well with adequate speech therapy, maybe a year or two. If your cochlear nerve shows hypoplasia, but the audiologist says that he is getting a robust response on maybe a TTEABR or a response audiologically, a behavioral audiometry for a child, then you should not just rely on the anatomy on MRI. Counsel the family, give them a guarded prognosis and tell them that although MRI is showing hypoplasia, but even if 30 or 40% fibers are transmitting, the child is showing a robust response on TTAVR or a premonitory stimulation test, what we call it, which is done under general anesthesia or sedation in the operation theatre. You should take these candidates for cochlear implantation. I have seen about 10 odd cases of cochlear hypoplasia. They've gone to a surgeon, they've got 1 year surgery done, they've not shown good response. Now the family has come to me and said, sir, we have done at a reputed center, this is what we have got. Should we go for the second year cochlear implantation? We know that it's a hypoplastic nerve, but then nobody can tell you how many fibers go. We can't tell at the transcortical level how many electrical potentials are being generated in the brain, that this is 30% of the normal cochlear nerve. But yes, you can take your chance, but then counsel them. And once you counsel them, you will avoid future problems in terms of results. So how we go about it? There is a difference in the modalities we get in this part of the world and in the Europe. In US and Europe, majority of them, they only get an MRI. The reason being why? They are just bothered about the nerves. That a cochlear nerve should be there, and if there is any anomaly, they can get an MRI. But where in India, we face a lot of medical legal part aspects. A CT scan is the first investigation which you get in the OPD for any patient who walks with a profound loss. And if we see that interaortic canal is less than 2.5 millimeter, and we suspect a cochlear nerve aplasia or inner ear malformation, an MRI should be done. However, at our center, we do both of them, and this is what we promote and propagate, that you should be well versed with your anatomy on CT and MRI. Now, how do you say that this is a normal cochlea and this is an abnormal cochlea? So the most important section which you should ask your radiologist to study the normal architecture in a cochlea and IP anomalies is mid-modulus section. As you can see, modulus is a quadrangular or a pentagonal structure. Only has really given a lot of insight into this. You can see the cochlear aperture, you can see the modulus, which is a quadrangular or pentagonal structure in the center of the basal turn. That's the basal at the middle and the apical turn. And in between these turns, you have the interscalar septa. These are the thick septas, which generally divide cochlea into 2.5 turns. So you have the basal turn, the middle turn, and the apical turn. Now the entire cochlear anomalies revolves along this diagram. Keep it in your mind. You should always correlate with this, and believe me, you will make your job very easy to identify. Now, a section, if you want to study the important structures, you can see the midmodalar, but one section below this, that is through the round windows, will show you the common, the basal term, the middle term, and the apical term. So, two things you should remember if you want to classify into anomalies. Number one is modulus there, interscalar septa there, number one. Number two, one section below, are all the terms present? These between the modulus and the term. This is dividing into parts. Interscalar septa. So, three things you should remember. Number one, see the modulus. Number two, see the interscalar septum. Number three, see the terms. This will classify most of the anomalies. Now, associated problems are of the vestibule and the left and the enlarged vestibular aqueduct. If you add these two to these things, you will classify all these anomalies into IP1, 2, 3, like okay. So let me see. This picture is in front of you. What do you think this is a case of? Yes. So the first thing, I'll tell you very basic mathematics. First thing you should see is the internal aortic canal. Can you see internal aortic canal here? Can you see it clearly? Tell me. Can you? Probably this may look like an internal aortic canal which is not well developed. Now what I told you in the first lecture, internal aortic canal divides the petrous part of the temporal bone into an anterolateral part which houses the cochlea and the posterolateral part which houses the vestibule. Can you see these two structures identifying? No. So what we are seeing the picture where we have a internal aortic canal maybe quite wide. We have a dysmorphic ossicles where this looks like maybe a stapes footplate area, but we don't have a distribution of this. This may be a carotid canal. We don't have a differentiation of a cochlea and vestibule. Maybe it is not formed. So like Pawan rightly said, we are dealing with a case of a mishra deformity, what we call as a complete labyrinthine aplasia. Simple. So first structure to see is internal aortic canal. From internal aortic canal, before you see other things, first thing you should see whether the internal aortic canal has bifurcated the petrous part of the temporal bone into an anterolateral and the posterolateral part. Cochlea is there or vestibule is there? If it is there, it is normal, it's a normal cochlea. If it is not there, then think about what kind of anomaly we are sharing. Okay, let me come to this. Okay, what do you see? Anybody, let us start so that you incorporate these basics in your mind and you don't face problems in your routine radiology. So, see, can you see a common cavity? When you say a common cavity, when you see a complete cochlea and vestibule, but there is no partitioning between it. So, can you see a common cavity here? Can you see a cochlea and vestibule here? This is probably the internal aortic canal. This is probably the internal aortic canal. That's a facial nerve. You can see a vestibule. You can see the canals. You can see the aqueduct here. Okay. Now, this is a condition where you have internal aortic canal, where you have a cochlea, you have a normal vestibule, but there is no cochlea. Can you see a cochlea here? You can just see the internal aortic canal, but there is no differentiation of internal aortic canal into the cochlea. You can just see a vestibule. So simple is, see, it is one cut. We are not talking about widening of the internal aortic canal right now. What I am focusing it's a cochlear aplasia with a normal vestibule. There is no cochlea which is developed, which you can see. This is the second classification. So what do we see here now? Okay, as compared to this radiology picture, you can see the vestibule is much more dilated. Agreed? Okay, you can see that the internal aortic canal is wide. Can you see? And maybe if you can have a cochlea here, it may be exposed directly into the internal aortic canal. And you have a facial nerve, tympanic segment of the facial nerve. You have a dilated vestibule. So as simple, we can't see any cochlea, we can just see a dilated vestibule. So this is cochlear aplasia, dilated vestibule. So we can have two kinds of cochlear aplasia. One is a Michel, no cochlea, no vestibule.
You have a vestibule, but you don't have a cochlea, but you may have a variation in the vestibule. Now what do we see here? Yes, it's a common cavity now. Can you see? You know, I have put only one section, but if you see, the cochlea and the vestibule has forming a common cavity. There is no differentiation, and this is very simple to read. So we don't have a differentiation. Now, this is a previous classification which was to be followed. But now what Levent Senegulu and Satsibun in 2002, that they studied the defect in the modulus and the interscalar septum. And what they came out was a classification which is most widely accepted in the world by surgeons, audiologists, rehabilitationists, which will give you an inside-out view about how to read it, how to implement it, what kind of electrode you should use, and what audiological outputs you can expect in this case. Number 4, it will also guide you what approach you should take, how your planning should be to do surgery in such case. Now, if I compare with the normal diagram, I told you to keep that mid-modulus section in your mind. Okay, that is the most important diagram which you should remember. If you see, can you see any modulus here? There is no modulus. Can you see any interscalar septum bifurcating into this? You cannot see. So you can see that there is no modulus, there is no interscalar septum, and it's an empty cystic structure with a large dilated vestibule. There is a defect between internal aortic canal and the cochlea, but the cochlea is located in the anterolateral part. Now, all these cases of IP1, 2 or 3, just remember the outer architecture and the inner architecture, the length, the dimension of the cochlea is the same. So they would require a normal array. There is no need to put a short array. You were talking about this because the external architecture and the internal architecture is absolutely right, absolutely normal. The problem is whether the septas are not differentiated, or they have a connection with the vestibule, or they have a connection with the ISC, or maybe they have got a facial nerve anomaly. But this doesn't warrant that you should select a shorter array in these cases. So this is what we call as a IP1 deformity. Now what we can see, remember these two things, there is absent modulus and interscalar septum. Now as you know that cochlear aperture, the cochlear nerve enters through the cochlear aperture, and we always focus that you should put an electrode array which is facing the modulus. It depends upon the type of electrode you are doing. Like in middle, you have a circumferential current. So, it doesn't matter you put it perimodular or you put against it. In advanced mechanics or maybe cochlear, if you put a straight array, you have to face it towards the modulus because the electric current is going to stimulate the ganglionic cells in the area of the modulus. Now, there is absent modulus and interscalar septum. There is an empty cystic structure. We have a large dilated vestibule, but vestibular aqueduct enlargement is there. Now, what I have understood, I'll show you. It should be somewhere around here, but it is not enlarged. I'll show you in the next where you have an enlarged vestibular aqueduct. Now, gushers, there is a difference between oozer and gusher. Generally, an enlarged vestibular aqueduct is going to give you a horrifying gusher. It will be difficult to control. I will come to how to manage a CSF gusher in your surgery, and I will show you a video also that I managed it how. So enlarged vestibule can give you a problem, maybe an oozer. If you are extremely unlucky, it can give you a gusher. But taking into consideration 90% of large vestibular aqueduct is going to give you a problem, and you should be mentally prepared to handle these cases. Now coming to IP2. Yeah.
How is that different from the cochlear aplasia study?
Cochlear aplasia, see, we are talking about Michel. See, Michel aplasia, there is no cochlea, there is no vestibule. Okay? Second, it was an old classification which says cochlear aplasia with normal vestibule and cochlear aplasia with dilated vestibule. Now that classification is over. What we are following world over is 11th classification, which classifies according to the presence or absence of the modulus and the interscalar septa. These are the two criteria which classifies into IP1, IP2, IP3 and IP4 now. Okay, now coming to IP2. Now IP2 is one of the most common anomalies which you see in your practice. It was first described by Mondini and what we call as a Mondini's deformity. The word Mondini triad should be restricted to if you have a minimal dilated vestibule. You are asking about a vestibular aqueduct. Can you see this? How wide it is? I will show you the next slide also. Now, if you just remember your first diagram, the modulus is there, but is the modulus reaching in the top? If you see the first diagram, the modulus was along with the interscalar septum, it was making a pentagonal structure. Can you see a pentagonal structure here? You cannot see. It means that the modulus is only limited to the basal turn of the cochlea. It is, I'll show you, it is not extending to the middle and the apical turn, number one. That is the most important thing. You have a minimal dilated vestibule, you don't have a big vestibule, but you have a large vestibular aqueduct. The apical part of modulus and interscalar septa are defective. You cannot see the modulus and the interscalar septum going to the apical part. If the interscalar septum doesn't go to the apex, it will not convert cochlea into 2.5 turns. It means that the basal turn would be present, but the middle turn and the apex turn is going to form a cystic apex. You will not be able to differentiate between the middle turn and the apical turn. It means there is no modulus, so there are no ganglionic fibers, although 90% of ganglionic fibers are present at the basal part. And what Dr. Murali said very rightly, when you drill the round window membrane, don't drill posterior-superiorly. The cochleostomy has to be anterior-inferiorly because the osseous spiral lamina and the modulus lies in the posterior-superior quadrant, and if you drill there, you will damage the residual modulus. So the patient will have a poor audiological outcome. Now this gives the absence of interscalar septum and the modulus gives the cochlear apex a cystic appearance, what we call as a classical Mondini deformity. Okay, now you can see you have the internal auditory canal, which is here. Can you appreciate the large vestibular aqueduct? It is very large. So while doing these cases, you should be mentally prepared that you will have a very bad gusher. And I will show you the video. We have a live video for this. And you have a vestibule which is not that dilated. It is partly dilated, but if you compare to vestibular aqueduct, it is not bad. So, Mondini's first thing we learned, the patient may not present to you because the audiology may show no hearing loss. A child may have a sudden loss at some age, and in that age group, you should always get a CT scan. Once you get a CT scan, you will make the diagnosis of a classical Mondini deformity. If the hearing status is normal, don't do anything. If the child starts to show hearing loss, put them on a hearing aid. Serially follow these kids, maybe 5 or 6 years. The moment they go into severe to profound loss or no progress on hearing aid devices, counsel them for cochlear implantation. With a guarded prognosis, I have operated one patient, I will show you a video. The child is doing quite okay, but then we told the parents that the audiological outcome of a Mondini is not going to be same of a normal child. You may have hiccups in between, the mapping issues are there because there is no modulus in the central part and the apical part of the cochlea. So again we are back to our first diagram. Can you see the difference now very well? Cochlear aperture is there. Modulus is maybe at the basal part, it is not going into the every part. The interscalar septums are not there, so you don't have a complete anatomy of the cochlea. This is Mondini only. Yeah, first side is the Mondini is the. No, I have shown different cuts to you to show where you find the enlarged. See, you You can't get everything in one cut. That is why I tell you to scroll them on a on the screen and not just on the CT scan. The only way to study anatomy is to sit with a radiologist. You will. CT scan. I have few in my. I use Osirix software for my Apple, and we load all the CDs and I will try. Actually, it's my new updated MacBook Pro, and I have it in the old MacBook. I'll just see if I can show you one. So very simple. You follow the mid-modular section. You follow the section inferior to the round window membrane, and you will differentiate. You will make a crucial decision about what kind of anomaly is it, and once you see the vestibule, you will be and the left and the large vestibular aqueduct, you will be able to prognose these patients for the outcome intraoperatively. Now, till the light comes, how these anomalies will make a difference in your surgical expertise? Now, that's a golden question. How to decide what kind of electrode or what kind of approach you do? Like I follow classical transmastoid transfacial approach. Transfacial approach was developed by our great house, and that's been world over accepted. In cases where you have IP1 or an IP2 or maybe an X-linked IP3, I'm not talking about common cavity. A transmastoid transfacial approach may be difficult, especially these cases are associated. 33% have got facial nerve anomalies. 33%. So please see the facial nerve. Facial nerve lies more anteromedial rather than running in the under the facial ridge, under the posterior canal. They are more anteromedial. They may cover the promontory or the oval window and the round window. And doing a facial recess may be quite risky because you can damage the facial nerve. So this is where transcanal approach was invented, and transcanal approaches, or it is quite useful in such cases. You can elevate the metal flap, you can see directly the round window, or maybe you can do a cochleostomy. Now surgeons started to face one problem, that you have to put the extra coils in the mastoid cavity. If you are doing a transcanal, then how do you place the electrodes into the mastoid cavity? So what they did, they dislocated the incus. What you can do, I did in one case, I will show you that video also. You can dislocate the incus, you can elevate the flap, you create more room for yourself, you do a cochleostomy or a round window access, and you pass your electrodes from superior area with an insertion. Of course, it has to go from the additors, not the additor. Because you take out the incus, so you create more room. You can't go to a transfacial facial recess area. So you dislocate the incus and you introduce the electrodes through it. So that's a transmastoid transcanal. So now we come to the IP3. IP3 is also called as X-linked deafness. It is supposed to have a little worse prognosis, and the IP3 patients don't do very well, but of course the only option what we have is a cochlear implant. Now what do we see in IP3? See, there is no modulus, okay? There is no modulus. Interscalar septum are present, but they are not reaching up to the down, or completely they are not reaching. And cochlea, if you see this part, that's the intra-aortic canal, and the cochlea is directly placed at the lateral end of the IAC. Now these are the cases where you would like to do a fluoroscopic guided insertion of the electrode array, because you can directly put the electrode array into the intra-aortic canal, and you can damage the facial nerve, you can damage the remnant cochlear nerve. A fluoroscopic guided insertion will save you from this, and you can rotate the electrode towards the superior part so that it takes a gentle curve inside. Now, there was a lot of confusion between hypoplastic cochlea and IP deformities. People used to interchangeably use hypoplastic definition for IPs, but this has been cleared by Reverend Sanangulu, and it says that hypoplasia should only be restricted when the cochlear terms are not well formed. Like I told you, very simple thing, either in IP1, IP2 or IP3, the external architecture, the internal architecture is the size and the dimensions are absolutely normal. The problem is of the modulus and the interscalar septum, plus problem with the vestibule and the vestibular aqueduct. So these all sum up into IPs, but if you are seeing dimension less than 2.5 or maybe cochlear 1.5 turn, classically type 3, you call it a hypoplastic type. Now this is further classified into word-like. This is based on radiological and histological. Now it has got very important significance. Now, would you like me to stress on the surgery part along with the type of anomaly, what type of electrode, so that it makes your fundamentals clear? Okay, let me then. So if we go into IP1, suppose you get a patient of IP1, you go to the CT scan, you find a facial nerve is normal. Okay, if the facial nerve is normal, then you can go with a normal transmascular transfacial approach. Since LPA enlargement is not there, there is just a minimal dilated vestibule. You can expect an oozon, maybe a gusher, but you will be able to control it. You may not need a lumbar puncture. I have got one patient where it got complicated. The patient was doing fine. I'll show you the video. And finally, we have to reoperate that patient with an LP, pre-op, intra-op, and post-op for 7 to 10 days, and it settled down. That was the case of Mondani's, and Mondani's has got a enlarged vestibular aqueduct. So all these cases, you can go for a classical transmascular transfacial approach. If there is a facial nerve anomaly, do a transfacial approach. Maybe take out the incus, insert the electrodes from the adductors, do a cochleostomy or a round window. Now, what literature says, all cases of classical cochleovascular anomalies, you should do a cochleostomy preferably rather than using a round window membrane. Now, what is the reason why? As you know, round window membrane is a natural anatomic pathway. You just peel off the membrane, you do a marginal cochleostomy or maybe an anterior inferior cochleostomy, you drill the area of the fenestra. But if you want to seal these patients, it is always easy to make a seal around the bone rather than around the soft tissue membrane, because that thud, that pressure of the CSF is going to push the electrode out. There have been cases which have been reported where exclusion of electrode array have occurred in the next 6 months because the pressures were not reduced and the seal was not proper, the electrode was pushed out. So prefer a cochleostomy if you want to see these cases where you suspect a enlarged vestibular aqueduct. Now coming to type 2, what we talk, Mondani's. Now these cases, since you have an LVA, you should be ready for a gusher. What you should do intraoperatively, you can go for a transmascular transfacial approach, which I did in one of my patients because the facial nerve was normal. Again, if the facial nerve is anomalous, you can go for a transcanal approach. Now, what steps you should take to avoid CSF leak or maybe a complication later on, or to have a complete insertion? You can do a lumbar puncture, but the first thing to do is, when you do a cochleostomy in such cases, see the pressure with which the fluid is coming. Ask your anesthetist to do reverse lateral work position for you. Leave for 10 minutes. Just cover that area and just chat with your staff nurse or your colleagues. Let the CSF flow off. The pressures are going to come down in the next 10 minutes. You will be able to insert. Most of the cases, when you insert the electrode, the basal part, if you are using a basisonic, then the ring. If you are using maybe the AV, the jaw, when it goes and fit into it, it will by itself, the pressure is going to get reduced and it's going to, the fluid is going to stop degressing. Use a periosteum. Periosteum is the best material to plug these ones. I've seen one surgeon from France. I saw him. What he used to do in these straight arrays, he used to have a periosteum. he used to make a hole in the center of the periosteum, pass the electrode through it, so that the periosteum used to stay at the lateralmost part of the electrodes, and once the electrode went in, he used to plug it the seal lining. Part of it insulates into the bone. Do a wide cochleostomy in such cases. Don't do a narrow cochleostomy, because if you have a wide cochleostomy, you will have that space where you can insert the fascia or the periosteum and plug this side. If you still feel that you have plugged it, the electrode has gone, still the pressure is pushing the electrode, then you can ask your pediatric anesthetist to do a lumbar puncture for you. Many people say that you shouldn't do, but I say make sure that when you close, there is no fluid in the mastoid cavity. If there is fluid, wait for 10-15 minutes. I don't shy away doing because I have burned my fingers once. I ask, and maybe after 2 days, you can take out the drain. It also reminds me, I was doing a case in Indore, and we were dealing with a labyrinthinus ossificans case with an extensive gusher. And in that center, we had no fibrin glue, and the lumbar drain was not there. They said we have got this urinary catheter drain. So I said it's not going to work. Finally, we got the drain, and we got the LP done intraoperatively, and we were able to insert the complete electrode. Sometimes the pressure is so much that the pressure doesn't go back even after 10 minutes. So you have to get an LP puncture done. So all these cases, you can go for a transmascular transfacial or this approach. Now coming to, I will talk about now common cavity. I can tell you, common cavity cases, you have a vestibule and you have a cochlea, and these two are combined together. You don't know where is the modulus because it's a common cavity. You don't know where are the vestibular elements. Most of these cases, the promontory is not well developed. The cochlear bulge onto the promontory is not there. If you do a facial recess approach, it is not required, because if you study your CT scan in common cavity, the middle anatomy is not well developed. You just have a common cavity with the cochlea and the vestibule. You do a transmastoid labyrinthectomy approach. Simple. Where you have the bulge of a lateral semicircular canal is where you mark that area, do a cochleostomy, you will directly enter into the vestibule. You insert the electrode, but cases of common cavity can have connections where it can lie just in alignment with the internal aortic canal. So see your CT scan. If you have fluoroscopy at your center, use it, and use a straight electrode. Don't use a curved array, because that can directly affect the results. These cases, you may have problem having vestibular stimulation when you do switch on. Ask your audiologist. Minimal amount of vestibular stimulation is okay, because the vestibular adaptation takes place in the next few weeks. But if you have got severe stimulation, then you may switch off those electrodes, which is causing stimulation. And that is how you do for a common cavity. So we got the second variety after the bud type is a cystic hypoplastic cochlea. So now the difference between IP 1, 2, 3 and this classification of bud-like or cystic hypoplastic is that the external and the internal architecture is small. So all these cases, you will not have a complete 2.5 turns, you will have less number of turns. As again, there is absence of modulus, interscalar septum, external architecture may be there, may be normal. Now these are the cases when it has got a complete communication with the internal aortic canal. You have a large vestibular aqueduct, vestibule is minimally dilated, gusher is expected. Whenever you have a large vestibular aqueduct, you should be ready for a gusher. And the electrodes can enter into the external aortic canal, and this is what we call as, you should have a fluoroscopy guide. Can you see this? So that's a vestibule, that's an internal aortic canal. You may have a cochlea, so you can have and see the large vestibular aqueduct. So plan your cases according to the finding. So then see, this is for academic purposes. Grossly, you may classify cochlea into when the cochlea is normal. It may be anomalous in terms of IP 1, 2, 3, but the dimension and size is same. And the second classification is hypoplasia bud-like with cystic appearance. Two broad classifications. Focus on IP 1, 2, 3. if you see that the normal architecture is not there, then think about hypoplastic bud-like. Now, in a bud-like cochlea, I'll give you how to approach such cases. There was a child, I was discussing with someone, and in a bud-like cochlea, you don't need to open the cochlea because the cochlea is just a small bud, so you don't do it. So in these cases, people do scalar vestibular insertions, or they see the footplate, they remove the footplate, and they introduce the electrodes into the hole. There is an article which has been published just a few months back, which says that of course they will get vestibular stimulation, they will get, but then vestibular adaptation takes place. So something is better than nothing, and the child in 4 years has shown considerable response. So even in hypoplastic bud-like cochlea, you have to counsel. Again, counseling is important. You can tell the parents that we don't have a cochlea, we don't have an option. But we have a chance where some cochlear and the neural elements are there. Of course, the impedances are going to be high, the electric currents are going to be high because you are away from the modulus or from the cochlear fibers, but you can introduce to the whole vessel.
And you were talking about common cavity, there is always a problem that electrode, terminal part of the electrode
goes into IAC. So this is what I am telling you.
Dr. Murali once told in his lecture that what he does is he makes a slit. He doesn't make a hole.
Yeah.
He just makes a slit.
That's a tire puncture.
Yeah.
Tire
and
puncture.
he just insert the curve of the electrodes.
Now, what Dr. Pawan is saying is absolutely right. Just like if you have seen people getting the puncture of the tube checked, what does that guy do? He inflates your tube and he dips that tube into this and he sees water bubbles. So what we do in a common cavity, if it has got communication with ISC, if it has got, then you take the electrode array, you do a wide labyrinthectomy on the area of the lateral semicircular canal, you pick up the tip of the electrode and the basal part of the electrode and you just insert it in a U-shaped fashion, where the tip comes out from the antler spot. Doing that, you are 100% sure that the tip is not going to go into the endonotic canal. 80% of your electrodes will submerge into the cochlear and the vestibular fluid, and it is not going to impinge onto any vestibular elements. Saying thus, the vestibular stimulation is less, you avoid entering the endonotic canal, and then you see that with periosteum of fascia. Now this was a child 2-year-old. He came with profound loss, bilateral profound loss. Now we saw his CT scan. See, the basal turn is there. The middle and apical are little fused, giving it a little cystic appearance. One section showed with the communication with the IAC, but it was only one section. Now you see this. The differentiation into 2.5 turn is not there. We identified the MRI. We could see the nerve going into the cochlea. We planned a classical, the fissure was normal. So we planned a normal post-order incision. I didn't do a lumbar puncture in him. I had an idea that he has an enlarged vestibular aqueduct. So we did a cortical mastectomy. I did a posterior tympanotomy. We opened the posterior tympanotomy. And I did a cochleostomy. I did not go through a round because I was expecting a gusher. So I did a wide, see my diamond I am rotating because I want to make a bigger cochleostomy. I don't want to make a small cochleostomy. The moment I did an opening, you see the amount of fluid. See, it is like a tap you have opened and you can't insert electrode in this. Okay, so I got the child head down, we fixed the implant. It was a 1J electrode we did and we got a complete insertion. And I packed it with the periosteum and I used fibrin glue. We use fibrin glue. It is recommended in the literature. And I waited. See, there is no fluid. It's completely dried up. We waited for 10. You can see some pressure. So we glued it with the periosteum around it completely. And once I did it, I waited for about. See, the pressures are high. It is going to push your periosteum back again and again. So you have to pack it you can enlarge the cochleostomy if you want. And I sealed it with the fibrin glue.
You are also using other periosteum while inserting the electrode so that to avoid the crushing.
No, once I have got complete insertion, Then I use the periosteum.
You were using some whitish thing when you were inserting the electrode.
No. Electrode was in. Once it was in, then I was using the periosteum. So coming to the last type is cochlea with less than 2 turns. Now, as you see, this is a till now we have read that all these anomalies have got normal architecture of the cochlea. The size and everything is same. Apart from this, where the length is less than 2, the interaction of the normal but smaller dimensions. Hence, you have got less turns. You may have a vestibular superior semicircular canal hypoplastic. If you see normal cochlea in such cases, normal cochlea means you have a normal cochlea. You may focus on two other anomalies. A wide internal artery canal, ampullary part is dilated. So, cochlea with less than 2 turns, they come into the classification of hypoplastic. It may be bud-like, it may be cystic-like, or it may be with less than 2 turns. Now, you have this large vesicular aqueduct syndrome. This is again given into the literature. You may have this, so suspect lot of gushers and oozers, lot of gusher in this, plan a lumbar puncture, and finally we have a narrow IAC. So that's the last classification in this. Now, if we see the width of the midpoint of IAC is smaller than 2.5, you should suspect an IAC. So go for an MRI. The first thing you go for an MRI, you won't be able to tell about the nerves in the internal artery canal. So go for the suction at the CB angle. Sit with your radiologist, try and trace the nerve. In case of narrow IAC, possibility of absence of hypoplastic cochlea, you must get MRI. So these are the cases as I have already discussed. Even with 30% of the nerves, you can expect a cochlear implant. Thank you very much for your patience.